Good evening. Welcome to our presentation this evening. My name's Tracy and I'm a trustee for Lynch Syndrome UK. This evening we have Demetra, who is a geneticist who works in Northwest London. And she's going to do a talk this evening about updates with LS. So it's over to you, Demetra. Welcome.
Thank you, and thank you very much for having me. So as Tracy just said, I worked in Northwest London, and I am working in a split role at the moment. So I am a genetic counsellor at Northwest Thames Regional Genetic Service, and also work at Imperial as a transformation manager. And most recently, I was offered a role as a lead genetic counsellor at the North Thames Genomic Medicine Service Alliance, where I'm working to basically help embed genomics in all aspects of healthcare, including in cancer genetics. And obviously Lynch syndrome is very close to my heart, and I'm working with quite a few colleagues trying to make pathways very smooth for patients and families with Lynch syndrome. Today, I will speak about updates that we have in this area in Lynch syndrome. And given that we didn't have the opportunity to have a conference last year, it will be updates, I guess, between 2020 and 2021. So I'll just share my screen. Right. Okay, so I hope you can see this. If you cannot see this, please do let me know. So as I said, I will speak about updates that we have or have had in the last 2 years. There's actually quite a few research updates. There's very important updates in Lynch syndrome management, which may have been discussed in the past by other speakers, but of course it's always important to go through them again. And I'll also talk about updates in genetic counseling research. We have had quite a few papers published in the last few years that were very important and had some very interesting findings. And also we'll talk about moving forward into basically how to make things work better for everybody. Just checking the chat. Perfect. Right, so I mentioned that we have had a few updates into Lynch syndrome research, and one of the most exciting updates had to do with the prospective Lynch syndrome database. For those who do not know what it basically is a data collection database where clinicians from all over the world are submitting anonymized data on families and individuals with Lynch syndrome in regards to their cancer incidents, how old they were, etc. And this way we get a better understanding of what the actual risks are of developing cancer when there is a diagnosis of Lynch syndrome. And also it helps understand how good the prognosis is. So I'll just go there now so that we can see this together. Again, Tracy, Mark, if you cannot see the page that I'm just about to show, please let me know. Great. So as you can see in this page, it's quite easy to find. It has some information about lifetime risks. Over here, we have got risk of cancer starting from 0 to 100%. And as we all know, there is no 100% risk in Lynch syndrome. And over here, we've got ages. So 25 years of age, 30, there's 50 over here, and there's 75. And as you can see, the risk between, for example, 25 and 30 is close to 0 or 0. And then from 30 onwards, it starts going up. And then it reaches this threshold here when one is in the 70s. Over here, interestingly, we can actually narrow it down to a specific body part, depending on what an individual is concerned about and depending also the decisions that they want to take. For example, let's go on endometrium. This here shows us the risk of endometrial cancer for a woman who has an MLH1 pathogenic variant. So as you can see, until the age of mid-30s, the risk is close to 0, and then it goes up. This is particularly helpful, especially for when women want to discuss surgery, for example, if they would like to take a risk-reducing option. And also another interesting thing here, if we scroll this, it can give us accurate risks based on the individual's age. So if we have a woman who's aged 55, for example, this will be her remaining lifetime risk over here. These risks are not to be taken as a rule. Obviously, they are as close as possible based on scientific data. And they are guides that we have to support decision-making. They're not necessarily the absolute truth, because of course there are exceptions in every rule. There are individuals that may develop cancer younger than 35 or younger than 25. And as such, we would like to take these as a general guide. Over here, as you can see, there's this vertical line here, which basically means that there is a deviation perhaps. So this specific risk could actually be somewhere between this little line there and there. So it shows us a bit of a range of where it actually could be. And the straight line here is the mean of where we expect the risk to actually lie. Over here, we can change risks as well. So we can, genes, we can change to MSH2, MSH6. And interestingly, in MSH2, there is a warning that the results are unreliable. This is because in this specific study, there were not as many PMS2 individuals recruited. And also, as you can see here, the range is actually quite big, which means we cannot really rely on this number over here as such. And I'll walk you through the PMS2 risks that we have published in the last few years in another slide. So essentially, this tool here is useful for individuals that have an MLH1, an MSH2, and an MSH6 alteration, but not PMS2 as such. So going back on the presentation. Here is a very nice paper that was published in the not so distant past by Sanne de Broeke. It's basically including the biggest data set from PMS2 individuals and families. And as you can see here, there's quite a few lines. It might be quite confusing, but essentially here we have a yellow line for female carriers. And this is over here, the cumulative risk of colorectal cancer. So over there, you can see that yellow line is following through very, very closely to the blue line, which is the male carriers. So up until the age of 80, we can see that the risk of colorectal cancer in males and females with PMS2 alteration variants is between 10 and 15%. This is very, very interesting because it's much lower than what it was originally thought to be, which is obviously very reassuring for anyone that has an alteration in the PMS2 gene. And what also is very interesting is that these risks do not increase until after age 35, as you can see from here. So we actually see the line picking up from the age of 40. This is obviously, again, good news, because PMS2 is not expected to be associated with very early onset colorectal cancer. Although, again, this is not a rule. Sometimes we do see individuals younger, but when we do see them developing cancer younger, such as in their 20s, for example, we do suspect of other causes as well, not just PMS2, Lynch syndrome as an isolated cause. And over here, we've got the endometrial cancer risk. The yellow line over here, the solid one, can show us that women that are past the age of 45 have an increased risk of endometrial cancer, which comes up to 10 to 15% by age 80. Again, this is lower than once thought. Something else that was very interesting that came out of this study was that we do not see a significant increase in other cancer risks in PMS2 alteration carriers, which again is very reassuring for these families. Here we have some more information from the prospective Lynch syndrome database. I know there's a lot of numbers, but I think what we need to concentrate on is these numbers here. So as you can see on the left, we've got type of cancer or organ affected by cancer. And these here on top are the most common types of cancer in Lynch syndrome, as we know. And this is very, very good, because we see that survival, 10-year survival of colorectal and gynecological cancer is quite high, and actually significantly higher compared to non-Lynch related cancers. So if we had, for example, to compare an ovarian cancer caused by Lynch syndrome and ovarian cancer caused by another condition or not Lynch syndrome, then we would know by definition that the Lynch syndrome associated cancer has a better prognosis. It is less aggressive and it's more likely to be treated well. So obviously this is amazing news, and it actually doesn't even include data that we have on immunotherapy. I would estimate that with immunotherapy, this might be slightly higher. Another important thing that we have found out and we're working on at the moment is that there's actually quite some data about the risk of developing a second colorectal cancer after being diagnosed with the first one. For example, let's imagine a patient called John. John may have developed his first colorectal cancer diagnosis when he was in his 30s and had successful treatment. He had his tumor removed, and 20 years later or 10 years later, John would still be at increased risk of developing a second cancer, and he may actually go on to do that. We have seen that individuals that have an extensive surgery following their first colorectal cancer diagnosis linked to Lynch syndrome do much better, which means that they are less likely to develop an extra colorectal cancer, given they have less colon left in their body. This is obviously a big decision to make if somebody is discussing operations and the type of surgery. But it is something that is available, and we suggest that individuals with MLH1 and MSH2 would be given the opportunity to discuss that with their teams. We do not have enough data on MSH6 and PMS2 carriers to suggest that they are indeed at very high risk of a second colorectal cancer. And for this reason, we wouldn't recommend they have such an extensive surgery. So what does that mean? Essentially, that means that we had a need to review our guidelines, and we had a need to review how we work, how we use this genomic information. So even though 10 years ago, we had this genomic information in hand to support family members, etc., but now they also help the individual. They help the individual choose the type of operation that'll be better for them. It also helps the individual discuss chemotherapy options as well as immunotherapy options. So it's very, very crucial to know what the cause of the cancer is in the first instance to make such decisions. And again, it's important to know that, of course, one size does not fit all. We may have different alterations. So as we spoken about before, there's different genes. Each gene has a different risk. There's also different individuals. We may have, for example, someone who's diagnosed very young, and they actually may wish to have such surgery because their remaining lifetime risk is greater than someone who's, for example, diagnosed in their 60s, whose risk of a second colorectal cancer is not very big. Of course, there's other factors as well that we would look into. There's other health status factors that come along. So it's important to put everything into context to help individuals make a decision that is good for them, for their own risk, and also for their own personal circumstances, whether that's social, whether that's to do with employment, etc. Here is a look of what we have worked on a year ago, actually, no, 2 years ago, guys. We created management recommendation guidelines that we have distributed across the UK. This was to help make things a bit clearer, because there are, of course, different genes, there are different risks, and there are different recommendations. So we wanted to ensure that everybody is given the same options. So here, as you can see, for MLH1 carriers, we would recommend 2-yearly colonoscopy from 25 to 75. And of course, Helicobacter pylori screening. And in terms here of risk-reducing surgery, we would also offer the option of hysterectomy with bilateral salpingo-oophorectomy once someone has completed their family. Of course, again, that is a very personal decision. And as with previous research findings, of course, we recommend aspirin as well. And in terms of management, as I mentioned before, this is now very important for cancer management. There's targeted therapies. There are surgical management options, such as a discussion of segmental, which is a small operation, versus extensive resection, which perhaps involves a larger part of the bowel. And of course, chemotherapy options may be different if someone has got Lynch syndrome. MSH2 is very much similar. The options are pretty much the same as with MLH1, given that the risks are very much similar to those as well. With MSH6, however, the colonoscopy is recommended from 35 to 75 instead of the 25 that used to be before. And over here, of course, recommend the same risk-reducing options to be discussed with women. Everyone should be given the information to make an informed decision for themselves. And with cancer management, immunotherapies as well as chemotherapy options should be discussed based on Lynch syndrome, the results. But we would not offer the option of extensive risk-reducing surgery because, as mentioned before, we do not have enough data to suggest that for MSH6 carriers. And with PMS2, again, it's similar with MSH6. Colonoscopy is offered from 35 to 75. However, with risk-reducing surgery, given that, as I mentioned before, the only two risks that we see in individuals with PMS2 alterations are colorectal and womb cancer, and not ovarian cancer, we would consider risk-reducing hysterectomy alone. And again, once childbearing is complete, after the age of 45. And that's because we only see that risk increase after that age. And again, with cancer management, we would not consider extensive surgery unless it's indicated with a specific cancer, and targeted therapies, as well as a review of whether chemotherapy is appropriate, should be offered. Everything that I just mentioned was actually agreed on this paper that Kevin has worked on with a big group of colleagues for quite a while. Actually, they worked on it for a long time because he had so many different subsets of updates. And it was actually published a couple of years ago, and he had very important updates that just cemented exactly what I just mentioned. We also had another important publication, which had to do with how the tumors develop. How do the normal healthy colon go on to develop an adenoma and a tumor? What changes need to happen to get it there? If we manage to understand the differences and what happens in the first stage, the second stage, the third stage of healthy colorectal tissue developing into an adenoma, and from that into a tumor, then firstly, we'll be more equipped to identify changes such as those. And secondly, we would know how to treat them, perhaps, because we would know more about them and what triggers them, etc. Interestingly, this group found that the likelihood of polyp development was higher in MSH2 alteration carriers, and that MLH1 tumors have different alterations and a specific different pathway that makes them develop differently. And it's a very good piece of work, because the more we know about how these differences occur and how they take place and which step follows another, then we'll be able to improve the detection and management of these adenomas and tumors. And moving on to another research finding. This is actually one of my favorite ones because it speaks a lot about what we need to do next. We have spoken a lot about the screening that we do, the management options that we offer, but then if people do not know they are at risk of Lynch syndrome, then all of the conversations we have had are not useful. And this is exactly what this paper is showing. So Menko et al. Have reviewed literature or research papers going through family communication. So essentially what they did was they reviewed how many families were seen in genetics, and then out of those, how many did communicate the result with relatives. And if they did, and when they did, how long was it after the very initial diagnosis? So over here, as you can see, there's actually quite a few studies. These numbers here represent a different study. Over here says basically who the study was following up. So once the individual was found with Lynch syndrome, this study was looking at everybody that is their first degree relatives and was at 50% risk. Over here, they were looking at individuals that had 100% risk, 50% risk, 25. And over here, they were looking at first degree relatives. And over here, we have the numbers of patients' relatives that were at risk. And they're actually pretty big numbers, as you can see, 286, 1,230, etc. And what they found is actually not many people were offered the test. or were tested. So we have here that 39% were offered the test by the Genetics Center. Over here, again, a bit higher, but still not 100%, nowhere near. And as you can see here, the numbers vary as well. Some studies have shown a big percentage, which is successful. Not to say that everyone needs to have a test, but at least everyone needs to have the opportunity to discuss what the familial condition is and what the options are for them. And over here, we see another thing that is a bit surprising, that it took them a long time to communicate these results. So over here, the median, which means basically the average, it took families to be informed was 82 months. And the range was between 10 to 140 months. Here we've got 8.6 years. Here we have 3 years, 12 years, etc. And that itself is a bit surprising, but also something of it as a pain point. We have to see it as a challenge that we need to solve. Not because we want to insist on everyone necessarily being seen by genetics, but at least they have to be informed of their risk, and also be offered some screening, which can detect cancer very early. They can have aspirin. They could have several options offered to them to ensure that they would be leading healthier lives. So again, it's important to inform relatives early because they would access screening earlier. They would have early management interventions and also improve family relationships. I found through work as well as through research findings that individuals who do not speak to family members about genetic conditions feel a bit resentful about not being offered the information on time, or perhaps about feeling the level of secrecy between different family members. And it does create a lot of tensions. And the next important thing here is health professional communication can also be improved. So this group here published a very nice paper last year, I think, and it showed that even though individuals were keen in having genetic testing, identifying the cause of their cancer, sometimes the communication between health professionals themselves was problematic in that they didn't know what to say to their colleague. They felt perhaps sending letters to colleagues would be too much or too little. It wasn't very clear on what the expectation would be on each party. And this is very important for us to decipher, because Lynch syndrome is one of those conditions that requires an individual to attend several appointments throughout time, perhaps across different specialties. For example, women may be seen by a gynecologist, they may be seen by a genetic counselor, they might be seen by a gastroenterologist. At some point, if someone wants to discuss family options, they may be seen by the pre-implantation genetic diagnosis team. So they see a lot of people, and it's important for all these people to speak together and also speak to their GP, who is the main provider. And this is, I guess, something that we perhaps need to focus on, especially now that we are addressing the issue of increasing the diagnosis, so ensuring that everybody with colorectal cancer and gynecological cancer, especially endometrial, gets offered a screening for Lynch syndrome as soon as they are diagnosed. Not only we need to do that, but we also need to communicate that result with everybody else. So how can we do things better? Again, as I just mentioned, we need to improve identification of Lynch syndrome families through reflex IHC testing or MSI testing soon after they are diagnosed with cancer. And this pathway can be quite complicated. Some of you may have been through it and understand that actually one waits for a few months to get through the pathway. We need to ensure that this pathway does not cause any problems to individuals in terms of them having any more delays, or in terms of them not having the test that they should have at the time that they should have it. We need to also improve the tailored management for Lynch syndrome carriers. There's actually quite a few colleagues, perhaps working in different sectors, that may not know exactly what needs to happen. So we have to communicate that. And we also need to help other colleagues learn about Lynch syndrome, firstly, and secondly, understand each other's roles in the patient's journey or the family's journey. And of course, there comes a point of thinking, well, could we find a way where we can give more power to individuals and families deal with everything if we give them the information, give them all the resources, and we help them discuss their history with their family. We help them provide their health professionals with all that they need to understand what needs to happen next. Maybe that would actually solve some of these problems. And I guess you may have already seen from Kevin's talk that there is a Lynch syndrome passport, and that gives a lot of power to someone because they have a record that shows when they need to have their screening, what alteration they're carrying, what needs to happen next, etc. And by having that, you can show that to your GP, you can show that to your gastroenterologist, you even could show that to somebody, for example, at A&E. Let's say if, touch wood, you turn up there with some pain and you want to be managed in the most appropriate way instead of having to have unnecessary investigations, if perhaps the first investigation that needs to happen is to check for any Lynch-related problems. We can also see how we can improve communication amongst families. I think that's a very tricky one because I guess families are very different and they have different communication styles. There are differences in terms of how different generations communicate as well. But there's definitely a space there for us to work together. So for you and for us as genetic counselors to work closer and discuss how we can best help you. Is there a resource that we can offer to you that can help you talk to your relative? Would you, for example, like to bring your children with you in an appointment where we can discuss things together? Would that make it easier? And there's a few ideas there that we can discuss to help improve all this. And as just briefly mentioned before, patient and family-owned information is also another very good key. We're basically heading in an era where everything is on our fingertips, right? So, you want to have a look at your bank statement, you just log in your app, you see everything. In the same way, if you want to look into, for example, life insurance or anything else that is also very serious and important in your life, you can do it by a click. Basically, go online, find things, and then 20 minutes later, you have your answer. And in similar fashion, we're working at the moment to create a patient-owned portal that can be accessed by the individual and their relatives when given permission, and also can be shared with other healthcare professionals. So you can share your digital file with another clinician looking after you. This is at the moment, in a way, trialed at Imperial, but I'm sure that there's many other hospitals as well that have patient-owned portals. And gradually we can get a lot of Lynch syndrome information on those portals to ensure that not only you have the information there when you need it, but everybody else, including your relatives and your healthcare professionals, also can access it, because it's not just about producing research that says things work. We also have to enable them to work. And of course, I'll be very interested to hearing your thoughts. In more recent times, COVID times, we also know that we were looking at fit testing in the Lynch syndrome population to help triage whether someone needs an urgent colonoscopy or not. And I would advise that you go to Kevin's talk, as he discusses these things much better than I can. So yeah, I think we can do this together. I think there's a lot to be done, but we are invested in this, and taking one step at a time, we can make things better. Thank you. Any questions?
Hi, Demetra. There's a question come through on our Facebook page from somebody watching live there. She's asking, is a 3-year colonoscopy ever recommended for any LS gene?
3-year?
Yeah.
Not as far as I'm aware. There have been a few countries, actually. It's quite interesting that I didn't mention the paper there. There was another study that was done by a European group that showed that there was no difference whether one did 2 years or 3 years. For the meantime, we do continue with 2-yearly in the British population. And I am not aware of a unit that would do it less often than that.
Okay, there's another one there as well. Obviously, due to COVID restrictions at the moment, what is the current waiting time for to see a genetic counsellor to get that initial appointment? Is there a backup in the service, or is it moving? Is it moving again now?
I guess we don't have. We were not as impacted as some surgical units. And in our unit, at least, the waiting time would be 2 to 3 months. In others, it might vary. I haven't heard of any other colleague mentioning that they have a serious breach, which means waiting times longer than 18 weeks.
Okay. There was another one here as well. Lady whose husband passed away in 2007 with bowel cancer. Her son had a few issues, but with colonoscopy tests that was cleared up. But now her daughter's presented with symptoms and has done for some time. She said, so how do we ask where to go with this gene test for getting LS? She's 36. And she doesn't know like where to start. She's suffering at the moment with a fissure, but it's never been treated properly. It's not clearing up. So how does she go about seeing whether LS is something in her family? Obviously, because her husband died so long ago.
Right. If did the husband pass away longer than 30 years ago? I'm sorry, I didn't hear if that was answered already.
It was 2007, sorry.
2007, that's fine. And it was colorectal cancer?
Yes, it was, yeah.
Yeah. I would suggest that the family seeks a referral to the genetics unit. Depending on where they live, there is one. Okay. And usually, for individuals that were diagnosed with cancer within the last 30 years, it's possible for us to initiate testing, given that they store a little biopsy sample from the time a relative or an individual was affected with cancer. And the beginning of the testing process is with that very biopsy.
Okay, so they would basically need to ask about getting a sample of their father's tumor in order to test that. Okay,
yeah,
that's brilliant.
And they can get that through their genetics unit. So they have to perhaps ask their GP to refer them. And that is what will be discussed during that consultation. For her daughter, you mentioned that her daughter has symptoms at the moment. Is that right?
That's correct, yeah.
Yeah, I'd also mention that to the GP. There is a history of early onset cancer in the family. We are concerned. There is that symptom that needs to be addressed, of course. And also at the same time, there needs to be this genetic referral initiated.
Okay. There was a question actually that was asked on our page. It was actually yesterday. A lady had a fit test as you described, and she's still having ongoing problems, but she hasn't actually heard any result back from that fit test.
Oh.
What would she need to do about that, and how would she initiate a conversation to get that information to make sure there was no problems?
Yeah. I think if 2 weeks have gone by and she hasn't heard anything from the test, for example, if she has had it, let's say last Wednesday, I'd say wait another couple of days to see if you hear anything. And if not, if it has been a few days and nothing has been offered to her in terms of an answer or the result, etc., I'd say this person raises it with their gastroenterologist, if they have one, or their GP or genetic counselor. So they can contact one of these 3 people and mention, I've got symptoms, my fit test hasn't explained why I've got these symptoms, what do I need to do?
Brilliant, thank you for that. And just a question from me actually. Obviously I was diagnosed quite some time ago, probably about 16 years ago now. But my family has actually gone through quite a lot of different cancers within that time. Do you think, as obviously as I'm getting older, my father's had problems with his bladder, with his kidney, and with his ureter. Do you think it's worth a conversation with the genetics department to actually implement maybe screening for myself? Because my dad's not the only person, and his sister has also suffered with the same problems.
Wow.
So I'm kind of wondering whether I should initiate a conversation with my genetics department, or would it be better through my GP?
I would say, gosh, it's a tricky one. I'd say start with your genetics department in saying, well, I understand, the typical risks are these, but actually in my family, it's been different. We've had this instead. Would you suggest I do any extra tests? We know that with, if I understood correctly, you're concerned about urothelial cancers, is that right?
Yeah, because both my aunt and my father have both had a kidney removed and a ureter removed as well.
Right. Yeah.
So yeah, and dad is having problems now with the bladder as well. So I'm kind of, obviously because we're MSH2, I'm quite concerned that, the obvious concerns, I suppose.
Yeah.
So where do I go from here?
Yeah. It's tricky because as far as I understand, the screening for urothelial cancers is not the best. But because you do have this family history, it is worth discussing with your local genetics unit to say, well, this is the case in my family. And it could have been that maybe in your family or another person's family, it's gastric cancer. And maybe there is perhaps a case to be discussed, as in, do we need to have a specific screening for this type of cancer that we had in my family specifically? It definitely is worth discussing all of these questions because they're valid. You have had the history, it's a fact for you. And also I think either would give you an answer that, well, yes, there will be screening, or if there is no screening, at least they will explain to you why this is not the case. And then there would be, or should be at least, a note to the GP to say, okay, so Tracy has this family history. If she ever presents to you with any of these problems, we suggest that you act on it immediately. That level of communication needs to happen as well.
Okay, thank you for that. There's another quick one on here.
Yeah.
I've noticed a lot of people on our support page say that they can't get children screened as they're below 18. Why can't the individual child be assessed rather than the blanket age?
Wow, great question. Yeah, because I agree. There's children who are 16 that are very mature, and there's individuals at 45, that are not as mature. You cannot really say age is the thing here. I, I would say that it would be reasonable if a child over the age of 16 wants to discuss something with a genetics team, they can. We have seen individuals in those ages to talk about late onset conditions. And they sometimes have very valid reasons as to why they want to be tested earlier, or they have some questions that they would rather ask a professional instead of their dad or mum. So I think definitely for an appointment, yes. And the genetic clinician would then assess whether there's a really good reason of why we can push this to happen earlier or not. It mainly is to protect the individual because firstly, they're quite young and the risks that we are dealing with only happen much later in their life. And there are insurance implications as well. So we want to ensure that the individual, took everything in and they are ready to deal with any outcome.
Perfect. Sorry, I'm doing a little look through there.
I can see a Q&A.
Can you see the question there? There's already a medical app for iPhone. Would it not be possible to add Lynch to this, or is it a fact that Lynch may be too big and varied for the general medical staff to take on board?
Yeah, it's a good question. So there are many medical apps. The difficulty with iPhones and Androids is that they have so many apps that are medical, which are not actually led by medical individuals. So you may have, for example, apps for diabetes that have indeed been verified and are validated and updated constantly to reflect all the changes in practice. And there are some that are not. And we want to target the ones that are fully updated, that people can trust and feel secure that if there's a change, it will be there. There are a few of those apps available. There are a few medical applications. For example, there's one, I forgot what it's called actually, but there is an application that medics use that has Lynch syndrome on it. And another way that we want to essentially get things, I guess, more out there in terms of Lynch is through either education, traditional conference education for GPs, etc., and providing the app for the patient to have. So through that patient's own hospital portal, where you log in with your NHS number, you check your upcoming appointments, your previous appointments, your diagnosis. There might be leaflets dropped in there for you occasionally with updates, research updates, etc. So we hope to get there as well.
Cool. There's another one here. What is the current time frame from first patient to Lynch diagnosis?
Ooh, okay. So if I understood correctly, we're talking about someone that has got cancer.
Yeah.
Who goes through everything. Okay. So we expect that from the moment someone has a biopsy and a cancer is confirmed on that biopsy, they should have the immunohistochemistry, which is screening test number 1, within a week or 2. After that, we expect that methylation studies, which is screening step number 2, may take up to 6 to 7 weeks. And then we expect that a genetics referral with a genetic test may take up to another 18 weeks. So I guess it's all added together, 18 plus 6, that's 24 plus another 2, let's say 26 weeks. And that's sadly
So around about
the
6
quickest.
months.
That's the quickest, because sometimes in real life, in between one test and another, there's an MDT. Then we discuss it in an MDT. Then someone has to write a letter. Someone has to sign that letter. The postman has to take it out. You know, just all of these small delays, but altogether they add up. It could be up to a year. Ideally, it should be 6 months.
Okay. And there's another lady here. If my daughter tested negative, does she still need to have colonoscopies?
No. So if in your family specifically, there was one parent with Lynch syndrome, because it could be both. If it was just the one parent with Lynch syndrome, and the daughter was tested for the specific alteration and she does not have it, then she wouldn't need to have any increased screening, because she doesn't have that additional risk. The only reason why she would perhaps need screening is if on the other partner's or the other parent's side, there is a risk or family history of colorectal cancer that perhaps warrants that individual continuing anyway.
Perfect, thank you. And double check, there's nothing else on that list and there's nothing else in my chat. That's it. That's the end of the questions for tonight. Thank you so much for taking the time and the effort to do this for us this evening. And a massive thank you to all of our lovely doctors in the NHS that have actually done the same as what you've done tonight. It's so greatly appreciated by the people, not only in our patient groups, but also on our websites and on our media channels as well. So thank you so much. Another quick question, another little one there, just saying fantastic information. Thank you so much in our little chat there. So thank you, Demetra.
Thank you so much for inviting me.
Yeah.
And also for all these questions. Thank you so much. I guess it's a sign that people are really engaged. And as a small request from me, if after this presentation you have some thoughts or some ideas or something, if you could email them through to LS UK or post them on Facebook so that we can gather people's thoughts and ideas, that'd be great for me to have, or for all of us working in healthcare to have, because sometimes we make assumptions about what people want or people need, and it may differ a lot from reality, and it's important to keep it as close to you as possible.
Definitely. I couldn't, that's a really great sentiment to end on. Thank you once again, Demetra. Very much appreciated.
Thank you.
Thank you. And you too. Speak soon. Bye.
Bye.